The question of the benefit of iron chelation therapy in myelodysplastic syndromes is an important question. Basically, for the moment, we don't have any prospective data potentially showing that iron chelation therapy improves survival in patients with myelodysplastic syndromes. So most of the data that we have to assess the benefit-risk ratio of iron chelation therapy in myelodysplastic syndrome are based on retrospective studies and registry studies. We know that iron accumulation in the body and high ferritin levels are associated with a shorter survival, and we know from these registry data that iron chelation therapy can potentially reverse the iron accumulation and potentially have some benefit on survival. But it's just retrospective data. So that's a question that some of our patients are asking us. How are we having the decision and the evaluation of the benefit-risk ratio based on this data, and what are the proofs that we have? And we need to be honest with them, telling them we don't have any prospective data showing that evidence. But interestingly, we have several independent registries and studies showing that we have a potential benefit on survival of iron chelation therapy. And maybe more than that, we also have our own clinical experience for some patients where we have some improvement not only in just ferritin levels, because treating a number is not what we need to improve the survival of patients. And for some patients with clinical experience, we can see the reversal, for example, of iron accumulation in heart or in liver for some patients. And that's also a big driver for decision.
Deferoxamine was the first iron chelation therapy agent that was available, and it's been shown very clearly in the congenital anemias that compliance with deferoxamine infusions impacts significantly on survival. So for patients who took their deferoxamine infusions on 75 days or less, the median survival was in the early 20s, whereas for patients who were fully compliant with deferoxamine infusions and took it on most days, the life expectancy was normal. And so, as a former colleague of mine used to say, I mean, what other tools do we have in medicine that improves life expectancy from the early 20s to normal? There are very few interventions that have that kind of an impact. So that's the congenital anemias. Deferoxamine is cumbersome. It's because of its short half-life, it has to be given by continuous subcutaneous infusion for at least 5 days per week for at least 12 hours per day. And so the patients have to carry around a pump with them. And in adolescent patients, that can be a real significant factor. I've actually found that in my MDS patients, who of course are usually older adults, that it's not such a factor when they can't have the oral chelators for various different reasons. Once they've made up their mind to do iron chelation therapy and that it's important, then the idea of the pump doesn't bother them so much. With deferoxamine, there is an increased incidence of ophthalmologic and ototoxicity at a ferritin level less than 1,000, and for that reason, that's where the ferritin threshold of 1,000 in the guidelines really originated. And so we do chelate patients and stop at, or don't stop chelation, but don't want to go under 1,000 because of this increased risk of toxicity. The therapeutic index is used to try to keep patients at a safe level where they won't experience side effects of deferoxamine. Deferiprone is the next chelator that became available. It is an oral formulation. It's not approved for use in MDS in Canada. It may be available in some other countries. It has been used extensively in the congenital anemias. It's given 3 times a day. So about 10 years ago, Deferoxamine became available, which of course is also an oral chelator, first the dispersible form and more recently the film-coated tablet.
The new formulation of Deferoxamine, the JADNEW, potentially brings a better tolerance profile for the patient. And nowadays, most of the patients treated with myelodysplastic syndromes and for who I consider the introduction of an iron chelation agent are now treated with Genu. Because we know that tolerance is a key to observance, and observance is a key to potentially efficient iron chelation therapy.